Alright, so this is the lumbar tray that we'll be working with. This is the manometer that's used to measure opening pressure. Here are a couple of drapes. You have a needle for the syringe, 3mm syringe. You have lidocaine. You break it open this way. You have 4 tubes that are numbered, and you fill them up sequentially, and I'll talk about those reasons later. You have a prep tray here, you have prep sponges here, you have an extension tubing, a battery, a Band-Aid for when you're done, and you have your spinal needle. So this spinal needle is it's a 20 gauge, 3.5 inch needle used for lumbar punctures. The patient will be in either a sitting upright position or a lateral recumbent position. You will palpate for the iliac crest. At the level of the iliac crest, you'll find that spinous process, and you go 1 inner space above or 2, depending on the body habitus of the patient, and that's where you will mark your needle point. You then begin to prep the patient for the sterile procedure. It's an invasive procedure, so you have to get patient consent. You can put the betadine or the chloroprep in here, and you pretty much dab it this way, and you go in a circular motion from the inside out, cleaning the area. So once that area is clean, you'll drape the patient with a drape over that area, and you get your 1% lidocaine, and you'll get your 3mm syringe, and you drop the lidocaine, and you'll introduce the lidocaine superficially initially, creating a circular wheel, and then you can go deeper. You can change the needle out if you need to go deeper. I think this needle here is longer, and you keep inserting, you keep putting more lidocaine in to numb up the area. Get the spinal needle out. The spinal needle has a little sheath, so you take that out. And it's a styleted needle. You have a stylet inside, and you want to keep that in there when you're introducing the needle. You'll tell the patient that there's going to be a slight discomfort. The most discomfort you'll get is with the lidocaine injection. This here, you should only be able to feel slight pressure. You'll have your area marked, and you want to go midline in between the spinous and the inner spaces. If we were working higher in the thoracics with the spinous process overlaying the segment below, you want to increase your cephalic angle to go past that spinous process. But since we're working with the lumbar area, normally just perpendicular to the surface area will be sufficient. So we'll introduce the needle in through our area. You'll traverse the skin, the subcutaneous tissue, and then the supraspinous ligament will be next, the inner spinous ligaments, and then the last ligament that you'll go through is the ligamentum flavum. Once you pass that ligamentum flavum, you'll be able to appreciate a pop or like a give. You'll feel it through the spinal needle itself. And when you feel that pop, you know you're in the epidural space. If you're given an epidural, you would stop there, and you would introduce the anesthetic or the steroid injection, whatever procedure you're doing. If you are doing a lumbar puncture, you would keep going through, slowly going through, passing the dura mater. You'll feel another pop, and then you'll be in the subdural space. Going through the subdural space, you'll go through the arachnoid layer, and you'll be in the subarachnoid space where you introduce, or where you get your CSF if you're going to be collecting CSF fluid, or if you are introducing a chemotherapeutic agent such as methotrexate for cancer patients. Once you're through, if you're doing a lumbar puncture, you would go in incrementally millimeters at a time, releasing the stylet and waiting for fluid to come out, CSF fluid. If none comes out, then you would advance the needle a little bit further until you get fluid coming out.
Let me try again. Keep on doing it. We can do it. There we go. Here we go. Almost there.
So we have spinal fluid coming out. I don't know if you can appreciate that on film. If you were doing opening pressures, you would get the stopcock here. Assemble the stopcock with the manometer. This stopcock valve, whatever direction it's pointing toward, is the off position. So if it's facing the needle, such as this, then no fluid will go through. So this is what we want. We'll remove the stylet. Place the stopcock within the needle, and right now it's off, so you get no opening, no CSF coming up through the manometer. In order for you to determine the opening pressure, you would move the stopcock in this out position here, allowing the flow to come from here, up in here, and not coming out here. So you open it this way, and you can kind of see the CSF rising within the manometer here. And ideally, the patient should be in the lateral recumbent position to get a more accurate measurement of opening pressure. So once the level of the CSF has stopped moving, kind of hovering in one position, you would note that in the patient's chart. Collect the CSF that's going through this manometer. In this case, you might have an assistant. Where's my assistant? So we'll hold the first tube in there, and then you would move the stopcock position toward the needle in order for this to flow out and into the tube. Once the fluid is collected, you can remove the manometer with the stopcock. And then collect some more with tube number 2, tube number 3, and tube number 4. Once that is done, you will reintroduce the stylet in the spinal needle and slowly remove the spinal needle from the patient and begin to bandage the patient up. You have an included band-aid within the kit itself, and then you are done with the procedure. Traditionally, you would have the patient lay supine for several hours after the procedure to prevent headaches or any other complications. I'm not sure about the validity of that statement, but it's been within common practice. Whoa, whoa, whoa! All right, so that's the lumbar puncture procedure.